Hi guys, this is Krista Joy Altabornal and this is my case study presentation on West African Trypanosomiasis. This presentation is based on the case study conducted by Elliott et al. 2014, that is on West African Trypanosomiasis in a returned traveler from Ghana, an unusual cause of progressive neurological decline. In the case study, a 69-year-old Caucasian man was admitted to the hospital showing symptoms of cognitive deterioration, sleepiness, and having balance problem. He was reported to have gone to Ghana where he experienced a lot of insect bites. His MRI scan showed gray matter changes in the frontal, parietal, and the brainstem area. Because of his travel history, the doctors considered trypanosomiasis in their diagnosis, so the patient was subjected to the immunofluorescent antibody test, and indeed, he tested positive. So after that, the doctors gave him eflornithine as a treatment for 14 days every 6 hours. Then the patient fully recovered. This case study exemplifies the importance of getting a full, accurate, and relevant patient travel history so as not to dismiss diagnosis of rare imported infection such as West African Trypanosomiasis. So this is the summary of the case study. Human African trypanosomiasis is actually one of the most neglected tropical diseases, and it is endemic in sub-Saharan Africa. So there are two forms, the West African trypanosomiasis caused by Trypanosoma brucei gambians and the East African trypanosomiasis caused by Trypanosoma brucei rhodesiense. So the West African version is actually the chronic form, while the East African is the more rapid form that can lead to deaths within 6 months. According to World Health Organization, 98% of trypanosoma infection is caused by Trypanosoma brucei gambians, while the other 2% is actually caused by Trypanosoma brucei rhodesiense. So because of this, the focus of this presentation will be on West African trypanosomiasis. Out of the 30 species and subspecies of Glucina, the Glucina faucipes and the Glucina palpales are the main vectors of West African trypanosomiasis. So they are commonly found in rural areas inhabiting thick vegetation along the riverbanks. The risk of getting trypanosomiasis increases with the number of times bitten by the tsetse fly. Here we see the Trypanosoma brucei parasite. So this is the cause of human African trypanosomiasis. So all the T. brucei species have long, crescent-shaped cells that has a single flagellum attached to the cell body by the undulating membrane. And it also has a mitochondria that has a kinetoplast. So they are usually 15 to 30 micrometers long, and they look like spindles in the mammalian tissue. And they are marked by their wriggling movement. Humans are actually the main reservoir for T. brucei gambians infection. So first, the tsetse fly takes a blood meal into the infected host, taking with it trypomastigotes. These trypomastigotes then transform into procyclic mastigotes in the midgut where they divide. Then, these procyclic trypomastigotes leave the midgut and then transform into epimastigotes. These epimastigotes then travel towards the salivary glands where they transform into mature metacyclic trypomastigotes. So, when the tsetse fly infects another or bites another person, these trypomastigotes will then be injected, causing another infection. However, this cycle is actually very complicated and it's a very low successful rate, meaning among the species of Glucina, there's actually 0.01% of these tsetse flies that carry a mature T. brucei infection. However, this should not be undermined since tsetse flies can actually feed 2 to 3 times a day, so it can infect a lot of people within its 2 to 3 month lifespan. The mode of transmission of the disease is by the following: the bite of tsetse fly, which is the main mode of transmission, mother to child, and there are rare cases of transmission via blood transfusion, sexual contact, and organ transplants. Here is a short video showing how tsetse fly transmit the disease. So the tsetse fly bites an infected host, carrying with it trypanosome parasites that also infect the tsetse fly. Afterwards, it bites another human being, transmitting the trypanosome parasites. Humans have an innate response against this parasite infection. So we actually have trypanosome lytic factors, or TLF. They're actually the natural trypanosome killers. And the expression of apolipoprotein L1 and haptoglobin-related protein helps to enhance the effect of TLF. So as you can see in here, the TLF binds to the receptor found in the parasite, and then this TLF is then delivered to the lysosome via endocytosis, and then the lysosome will then activate peroxidase that will cause oxidative damage to the cell, and then this will result in cell lysis and will kill the parasite. During a trypanosome infection, a lot is going on in our immune system. We have the innate immune system and also the humoral immune system. So it's worth noting that whenever we have infection, the polyclonal B cell is activated and there's a high number of IgM concentration, and also there are macrophages that actually help in phagocytizing the parasite and helps in the secretion of important molecules or cytokines and prostaglandins that help in fighting the parasite. Sadly, the parasite also has developed a few protective tools that allow it to evade the immune system. So what happens is that they have the expression of the antigenic variant surface glycoprotein, or VSG, in their surface. So what happens is that the trypanosomes will shed the VSG and then they change into a new variant surface type that is not affected by the immune system. So as you can see here in the picture, in the presence of antibodies, there are a few parasites that has a different color. So this have different VSG. So what happened is that when this antibodies like IgG or IgM attack the parasites, some of them will continue to survive because they aren't detected by the immune system. And another thing, they also have an increased number of sustained protease activity that reduces their binding affinity to the lytic factor. So they continue to survive and proliferate in the human body. This video shows the protective mechanism of trypanosomes. So as you can see in here, they are shedding their new VSG protein that is not detected by the immune system. T. brucei gambians is actually a very dangerous parasite because it can actually invade the blood-brain barrier and infect the central nervous system. So it can do so because the parasite has increased cysteine protease activity that allow it to degrade some of the proteins in the intercellular junction. So shortly after infection, trypanosome migrates to the blood and to the lymph where they reside and multiply. So in this stage, the patient experiences a lot of symptoms, vague symptoms that make the disease very difficult to detect early. So this includes headaches, fever, enlarged lymph nodes. This is a very prominent sign, the winter bottom sign. And then we have muscle, joint pain, we have chancre, large sore at the tsetse fly bite, and they can have rash, and they can also experience weight loss. So meningocephalic stage 2 is the advanced stage wherein the parasite already invaded the blood-brain barrier, is now infecting the central nervous system. So patients experience disturbances in sleep wherein they sleep a lot during the day but they have difficulty sleeping at night. They experience confusion, a lot of memory impairment. They change behavior, feeling of irritability, sensory disturbance, and poor coordination. So they experience like balance problems. So since West African Trypanosomiasis is also known as Gambian sleeping sickness, so the sleeping disturbances are very prominent among patients. So this is because the parasite is already infecting the organs responsible for the circadian rhythm, such as the median eminence and the posterior pituitary. So these are the methods used in diagnosing West African trypanosomiasis. So the first three relies on antibody detection, that is involves the variable antigen type LITAT 1.3 and TB Gambians. And then the last three involves parasite detection. So looking at the microscope to view if the sample has trypanosome. This rapid antibody test involves the collection of patient blood. So card agglutination trypanosomiasis test, or CAT, is actually the primary tool used in endemic regions in Africa. But it is known to give false positives, especially in people also infected with other parasites such as malaria. This two antibody test has just been recently developed, and they are also known to have high accuracy and specificity rate. So enzyme-linked immunosorbent assays are actually used in screening suspected cases in non-endemic countries. So this is how parasite detection can be done. So lymph node examination is done for people who have tested positive for rapid tests, while CTC or capillary tube centrifugation has actually a detection limit of 500 trypanosome per ml and needs at least 4 capillary tubes from the person. And next is the MAECT or mini anion exchange centrifugation technique that has a very high diagnostic sensitivity of 77%, that it can detect 30 trypanosome per ml of blood sample. This is a video of a trypanosome found in the blood film. See how it is moving. So stage diagnosis can be done by doing a lumbar puncture to collect the CSF or cerebrospinal fluid. So WHO has a diagnostic criteria, that is the patients with fewer white blood cells and no trypanosome in their samples belongs to the stage 1, while those with more than 5 white blood cell or trypanosomes per microliter indicates the stage 2. So here are samples of cerebral CSF with trypanosome. First stage treatment drugs are actually a lot safer than the second stage drugs. They are well tolerated by the patients and they have less severe reactions. So pentamidine is actually the main drug of use for early stage. It is given intravenously or intramuscularly for 7 days and has minimal side effects, while suramine is actually more used for TB Rhodians infection rather than the TB Gambians infection, because it is known to have severe side effects such as fatal allergic reactions, and is usually administered via intramuscular injections for 5 to 7 days. So second stage treatment drugs are actually very dangerous to health because they can now cross the blood-brain barrier. And then the main choice of drug therapy for the advanced stage is the nifortimol ifarnitine combination therapy, or NECT, that has a high cure rates of 95 to 98%. It's less associated with severe reactions, and has lower dosage and duration. So their synergic effect together allows simpler administration and lowers the chance of parasite resistance. Fixinidazole is a very new drug oral treatment that is just approved last 2019. So it's known is usually used for non-severe second stage, and it's actually very well tolerated by the patients and have less serious side effects. Millarpusol is the most powerful trypanoside available. However, this is not usually used by doctors because of its fatal side effects that can have 5 to 10% fatality rate because of um, experience of coma, seizures, and cerebral edema. So parasites are actually very difficult to kill. So it is important that patients will have to be monitored and checked for up to 24 months to ensure that they are free from the trypanosome. We know that humans are actually the main reservoir for TB Gambian infection, so it's important to early detect those people who are infected and then treat them right away. And then we also know that this disease is actually transmitted by tsetse flies. So we do vector control programs that involves aerial insecticides, ground spraying for the pupal stages of tsetse fly, and now we also have tsetse fly traps that is used by a lot of people in Africa. We can also avoid West African Trypanosomiasis by avoiding the bites of tsetse flies. So we can have mosquito nets. We should also wear neutral colored clothes because these flies are attracted to very dark or very light clothing. And we can also carry insect repellent and also wear long sleeve medium weight clothes. Thank you so much for listening. I hope you didn't fall asleep.